Welcome to Explain, a series of health education programs published by the Patient Education Institute, the leading provider of interactive health education. This video includes general medical information and does not replace the medical advice of your doctor or healthcare provider. If you have questions pertaining to your medical condition, ask your doctor or healthcare provider. Inducing Ovulation with Clomiphene Citrate. Introduction. Approximately 25% of infertile women have problems with ovulation. These include the inability to produce fully matured eggs or the failure to ovulate. The inability to produce or release eggs is called anovulation or oligoovulation. Fertility specialists use a group of medications, often called fertility drugs, to treat ovulatory problems and increase a woman's chance for pregnancy. Fertility drugs may also be used to treat unexplained infertility. This patient education tutorial explains normal ovulation and the causes and diagnosis of anovulation. The benefits and risks of treatment with the fertility drug Clomiphene Citrate are also explained. Reproduction. The female reproductive organs are located in the pelvis between the urinary bladder and the rectum. They include the ovaries, the fallopian tubes, the uterus, the vagina. The ovaries are two small glands with two main functions. 1. The production of specialized hormones such as estrogen and progesterone. 2. Maturation of the eggs in the ovary and ovulation, which is the release of eggs needed for reproduction. Ovulation is an essential factor in conceiving a child naturally. About once a month, an egg matures in a fluid-filled ovarian cyst called the follicle. The egg is released by one of the ovaries and is picked up by the fallopian tube. If healthy sperm are ejaculated in the vagina after ovulation, the spermatozoa swim up the female reproductive tract through the fallopian tube to fertilize the egg. The fertilized egg begins to divide and becomes an embryo. The embryo travels through the fallopian tube and into the uterus, where it implants in the uterine lining. The uterine lining is called the endometrium. The embryo's journey through the fallopian tube to the uterus takes 3 to 5 days. 3 to 4 days after the embryo reaches the uterine cavity, it will implant. If the egg is not fertilized or the embryo fails to implant, the endometrial lining that develops in preparation for pregnancy sheds. This is known as menstrual flow. Menstrual cycle and ovulation. The menstrual cycle is divided into 3 phases based on time in the cycle. 1. The follicular phase. 2. The ovulatory phase. 3. The luteal phase. These will be explained briefly in this section. These phases illustrate the importance of hormones in ovulation. The follicular phase. The follicular phase usually lasts about 10 to 14 days, beginning with the first day of menstruation and lasting until the luteinizing hormone LH surge just before ovulation. During the follicular phase, the hypothalamus, which is an area of the brain, releases a hormone that signals the pituitary gland, located right beneath it at the base of the brain, to release follicle-stimulating hormone, or FSH. FSH stimulates the development of several follicles in the ovaries. These follicles contain immature eggs. One of the growing follicles will become the dominant follicle, and its egg will reach full maturity. The other follicles that were stimulated stop developing, and their eggs degenerate through a process called atresia. The dominant follicle increases in size and secretes estrogen into the bloodstream. The rising levels of estrogen cause the hypothalamus and pituitary to slow the production of FSH, follicle-stimulating hormone. The ovulatory phase. The ovulatory phase begins with the LH surge and ends with ovulation, which is the release of the egg from the dominant follicle. As ovulation approaches, estrogen levels rise. This triggers the pituitary gland to release a large amount of another hormone, LH. This is known as the luteinizing hormone surge. About 32 to 36 hours after the onset of this LH surge, the dominant follicle releases its egg. The luteal phase. The luteal phase begins after ovulation and generally lasts about 12 to 17 days. After the egg is ovulated, the empty follicle that contained the egg becomes known as the corpus luteum. The corpus luteum secretes large amounts of progesterone, a hormone that helps prepare the endometrium for implantation of the embryo and pregnancy. If the egg is fertilized by a sperm, the resulting embryo reaches the uterus a few days later and begins to implant in the endometrium. If an embryo does not implant, the corpus luteum regresses and progesterone levels decline. As hormone support is withdrawn, the endometrium breaks down and is shed in the process of menstruation, and a new cycle begins.
Sponsored by the Patient Education Institute. www.patient-education.com. Over 5,000 videos and interactive tutorials.
Anovulation. The causes of anovulation or failed ovulation are varied. Your doctor will first try to determine the cause of anovulation before medication is administered to stimulate ovulation. Whenever possible, treatment should be directed at correcting the underlying cause of anovulation. If such treatment fails or is not possible, ovulation drugs may be used to stimulate ovulation. The causes of anovulation include polycystic ovarian syndrome, PCOS, insufficient production of LH and FSH, follicle-stimulating hormone, by the pituitary, hypogonadotropism, premature ovarian failure. Other causes of anovulation include thyroid disease, prolactin excess, obesity, eating disorders, extreme weight loss or exercise. Even though your cycles may continue to be regular in your 30s and 40s, the egg that ovulates each month tends to be of poorer quality than those from your 20s. During your 30s and 40s, your physician may suggest evaluation of your ovarian reserve, testing which provides information about the number and quality of your remaining egg supply. The results of an ovarian reserve test help to predict your chances to get pregnant with treatment. Sometimes the cause of anovulation cannot be identified confidently. If a woman never ovulates or ovulates only occasionally, the hormonal signals to the uterine lining are disorganized. As a result, she may not menstruate at all, or she may bleed irregularly and unpredictably. Menstrual cycles can also be fairly regular even in women who do not ovulate. Ovulation drugs are used to treat women with irregular menstruation or no menstruation. Irregular menstruation is known as oligoovulation. Lack of menstruation is known as amenorrhea. Diagnosis. Ovulation can be detected and confirmed in several ways. A woman who menstruates every 21 to 35 days is probably ovulating regularly. She also can assume that ovulation occurs about 14 days before the first day of each menstrual period. Because a variety of problems can prevent or disrupt ovulation and result in infertility, it is often necessary to determine whether or not a woman is ovulating. There are several ways to detect ovulation, including urine test kits to measure LH levels, transvaginal ultrasound to look for development of follicles. Other ways to detect ovulation include blood tests to measure hormone levels such as LH or progesterone, the basal body temperature (BBT) chart, endometrial biopsy, which is infrequently used. Urine test kits to detect the LH surge. Several ovulation prediction tests are available at drugstores. These kits use test strips that show changes in the level of LH in the urine. Once the LH surge has occurred, ovulation usually takes place within 12 to 36 hours. Urine testing should begin about 2 days prior to the expected day of ovulation. For women with 28-day cycles, ovulation usually occurs on days 13 to 15. For women with irregular menstrual cycles, urine testing should be timed according to the earliest and latest possible dates of ovulation. If the cycle ranges between 27 to 34 days, ovulation should be expected to occur between days 13 to 20. Therefore, testing should begin on day 11 and continue until ovulation is indicated, or through day 20. There is about an 80% chance of detecting ovulation with 5 days of testing, and about a 95% chance with 10 days of testing. Once ovulation is documented, it is no longer necessary to continue testing during that cycle. Occasionally, ovulation may not occur in a particular cycle. If ovulation is not detected in 2 or more consecutive cycles, an ovulatory problem may be present. Transvaginal ultrasound. Follicular growth and the number of follicles can be measured with ultrasound, a technique which uses sound waves to produce an image on a monitor screen. This is a painless procedure, usually done with a probe inserted into the vagina, but it may be done with an external probe placed on the abdomen. Prior to ovulation, the follicle is thin-walled and filled with fluid. As the egg inside the follicle develops, the follicle increases in size. Ovulation generally occurs when the follicle measures about 1.8 to 2.5 centimeters in diameter. Ultrasound may be useful for timing intercourse or insemination. In women taking fertility drugs, ultrasound may be performed on several different days during the menstrual cycle so that each follicle can be measured accurately and its growth can be monitored. Blood tests to measure hormone levels. The LH surge occurs just before ovulation. LH levels in the blood or urine can be measured to predict when the follicle is mature and ready for ovulation. Estrogen is secreted by the growing follicle and rises rapidly prior to ovulation. If ovulation is being induced with fertility drugs, frequent estrogen level measurements may be needed to determine follicular growth. Elevated progesterone levels in the blood usually mean that ovulation has occurred. A blood test to measure progesterone can be performed about 1 week before the next expected menstrual period to confirm that ovulation has occurred. Blood progesterone levels are not used to predict when ovulation will occur. Basal body temperature (BBT) chart. The basal body temperature chart helps monitor the duration of each phase of the menstrual cycle and can help determine if and when ovulation has occurred. During the follicular phase, a woman's body temperature is relatively low. When progesterone production begins at ovulation, it produces a temperature rise with a minimum increase of 0.5 degrees Fahrenheit. The BBT usually rises 1 to 2 days after ovulation has occurred. An increased body temperature for several days indicates ovulation has occurred. Although BBT charts cannot precisely predict when ovulation is going to occur, they may assist a couple in identifying their most fertile week. They can also confirm that ovulation has occurred. Some women will monitor changes in their cervical mucus along with their BBT. As ovulation approaches, a woman's cervical mucus becomes more abundant, thin, slippery, and stretchy. This can be an inexpensive, natural way to help identify a woman's most fertile days, but many women find it is not that helpful because the mucus changes are difficult to interpret. Ovulation medication. Medications for inducing ovulation are used to treat women who ovulate irregularly. The most commonly prescribed ovulation drugs are Clomiphene Citrate, FSH, follicle-stimulating hormone, human chorionic gonadotropin, HCG, human menopausal gonadotropin, HMG. Other ovulation drugs with specialized applications include bromocriptine, cabergoline, GnRH, gonadotropin-releasing hormone, GnRH analogs, insulin-sensitizing agents, LH. Ovulation drugs can also be used to stimulate the ovaries to produce more than one mature follicle per cycle, which leads to the release of multiple eggs. This controlled ovarian hyperstimulation, COH, or superovulation, may be accomplished with either oral or injectable fertility medications. Superovulation combined with intrauterine insemination, IUI, is used to treat several forms of infertility. The intent is to develop several mature eggs in hope that at least one egg will be fertilized and result in pregnancy. Controlled ovarian hyperstimulation is also an important component of IVF treatment. Clomiphene citrate. The most commonly prescribed ovulation drug is Clomiphene Citrate, or CC. Brand names include Clomid and Seraphine. This drug is most often used to stimulate ovulation in women who have infrequent or absent ovulation. The usual starting dosage of CC is 50 mg mg per day for 5 consecutive days. Treatment begins early in the cycle, usually on the 2nd, 3rd, 4th, or 5th day after menstruation begins. If a woman does not have periods, it can be induced by administering progesterone or some other progestin. If ovulation does not occur at the 50 mg dosage, CC may be increased by 50 mg increments in subsequent cycles until ovulation is achieved. Although dosages in excess of 100 mg are not approved by the Food and Drug Administration, your physician will determine the appropriate dose for you. Occasionally, the physician may choose to add other medications to clomiphene if the drug is not successful in inducing ovulation. Clomiphene works by causing the pituitary gland to secrete more FSH, follicle-stimulating hormone. The higher level of FSH spurs the development of ovarian follicles that contain eggs. As the follicles grow, they secrete estrogen into the bloodstream. If treatment is successful, about a week after the last tablet of CC is taken, the pituitary is hypersensitive to GnRH and releases an LH surge. The LH surge causes the egg to be released from the mature follicle in a process called ovulation. It is important to determine whether a given dosage of CC results in ovulation. Most doctors rely on the menstrual pattern, ovulation prediction kits, measurement of serum progesterone levels, or the BBT chart to monitor a patient's response to the standard dose of clomiphene. Intrauterine insemination is frequently used in conjunction with CC. Clomiphene sometimes can alter endometrial thickness, making it thin and unreceptive to implantation. The lowest dose of clomiphene, sufficient to induce ovulation in anovulatory women, is usually used for at least 4 to 6 cycles. This serves as an adequate trial for most patients. Clomiphene will induce ovulation in about 80% of appropriately chosen patients. About 40 to 45% of couples receiving clomiphene citrate will become pregnant within 6 cycles. Most authorities suggest that CC be given for no more than 6 cycles because the chance of success with longer durations of treatment is quite low. After that, alternatives may be considered. Women who have irregular or absent ovulation due to hypothalamic disorders or who have very low estrogen levels generally do not respond well to clomiphene. Women who are obese may have better success if weight is lost. Risks. Clomiphene is generally tolerated well. Common side effects include mood swings, breast tenderness, and nausea. Hot flashes occur in about 10% of women taking CC and typically disappear soon after treatment ends. Occasionally, CC also may cause ovarian or pelvic discomfort. In some women, the drug also can have adverse effects such as thickening the cervical mucus, making it less receptive to sperm, or inhibiting endometrial growth, resulting in a thin endometrium that is unreceptive to implantation. Rare side effects include severe headaches and visual problems, such as blurred or double vision. These are usually temporary. If these side effects occur, it is prudent to stop treatment immediately and call your physician. Women who conceive with clomiphene have approximately a 10% chance of having twins. Triplet and higher order pregnancies are rare, less than 1%, but may occur. There is no increased risk of miscarriage in pregnancies conceived with clomiphene therapy. Ovarian cysts, which can cause pelvic discomfort, may form as a result of the drug's overstimulation of the ovaries. A pelvic exam or ultrasound may be performed to look for ovarian cysts before beginning another clomiphene treatment cycle. Side effects are more frequent with higher doses. It has been suggested that women taking ovulation-inducing drugs such as Clomiphene Citrate may be at increased risk for ovarian cancer. Recent studies and reanalysis of earlier studies do not support this connection. After years of clinical use, physicians can advise patients confidently that Clomiphene Citrate is not associated with an increased risk of birth defects.
If you like this video, please like and share. For similar videos, subscribe to our channel.
Conclusion. Lack of ovulation is a treatable condition. As a result of treatment, there is hope for many infertile couples of achieving their goal of having a child. Medications for inducing ovulation are used to treat women who ovulate irregularly. Clomiphene citrate, or CC, is one such drug. Clomiphene will induce ovulation in about 80% of properly selected patients. About 40 to 45% of couples receiving Clomiphene citrate will become pregnant within 6 cycles. Like any drug, CC has side effects and potential risks. Learning about them may help you detect them early if they happen. Your doctor will discuss with you in more detail fertility treatments and drugs that may help you to achieve pregnancy. Do not hesitate to ask any questions that you may have. Thank you for using Explain.